The basic principles of CRRT are similar to those we've covered in intermittent dialysis. Now, in intermittent dialysis, the bulk of solute transport is through diffusion. And we don't really pay so much attention to the small molecule clearance that occurs with convection. Okay. There is small molecule clearance that occurs with convection. It's just much smaller than that which occurs with diffusion. Now, with CRRT, they're often similar. The amount of clearance with diffusion is similar to the amount of clearance with convection, and that's because you prescribe it that way, not because of any mysterious, um, you know, change in physiologic principles. It's just that you prescribe replacement fluid uh, instead of just um, achieving convective clearance through ultrafiltration that you prescribe. So ultrafiltration in hemodialysis is the reason for some modest amount of convective clearance, the reason you have more meaningful, proportionally more meaningful convective clearance with CRT is because you add replacement fluid. Okay. Now, the I will say, just as an aside, Huzair did a presentation on the addition of convective clearance to hemodialysis and showing some improvements in certain outcomes with that. That is not standard of care in the US, though. So there is, even in hemodialysis, there's ways to prescribe more convective clearance beyond the ultrafiltration that you prescribe. But once again, that is not standard of care, and I will point you to Huzair's Journal Club to learn more about that and the outcomes that can be achieved with that. All right, so hemodialysis, of course, refers to diffusive clearance and the movement of solutes down their concentration gradients. And this is especially efficient with the movement of small solutes. Convective clearance moves solute through solvent drag across a semipermeable membrane. We'll go through some of these pictures. Well, I'll go through it now. So here is an example of convective clearance. Okay. In this model of convective clearance, I have a blood urea nitrogen concentration that may be 100 milligrams per deciliter. I move that blood through the blood compartment. I apply a transmembrane pressure across that membrane. That pressure pushes fluid across that membrane. The membrane properties are such that there is no impediment to urea flux across the membrane. Urea is sufficiently small, the pores are sufficiently large, that essentially this urea flows through that membrane without any impediment. If that's true, then the urea concentration in the blood and the effluent urea nitrogen would be equal. Okay, EUN I've used to refer to effluent urea nitrogen. You can see is 100 milligrams per deciliter. That effluent is dropped down the drain, so of course you're getting urea clearance. The blood, as it returns back to the patient, remains at a concentration of 100. Even though I'm removing fluid or urea from the patient, I'm also removing fluid from the patient. So this is akin to taking a bucket. All right, I often use this analogy. The concentration of urea in that bucket is 100, right? And I simply poke a hole in this bucket. Urea leaves the bucket, yes, of course, but the concentration of urea doesn't change when I remove water at a equal proportion, right? The concentration is still 100. So that's what's happening across this circuit, the way that urea concentrations actually drop is the addition of replacement fluid, okay? So the movement of solutes through solvent drag, or the application of this transmembrane pressure and the movement of water across that membrane, bringing it solutes, is hemofiltration, okay? This is more effective than diffusion for moving larger solutes. You can think of it as functionally, when I increase the transmembrane pressure, I functionally increase the pore size in this semipermeable membrane, and therefore increase the movement of larger molecules. Remember, we talked about phosphorus. Even though it's a relatively small molecule, it acts like a middle molecule because of its shell of water molecules around it. So if I'm interested in clearing more phosphate, if I'm interested in clearing vancomycin in a patient with vancomycin toxicity, I might preferentially apply hemofiltration, okay? A way that describes the ability of solutes to move across a semipermeable membrane with hemofiltration is sieving coefficient, okay? That is a mathematical relationship that describes the concentration of effluent solute compared to the blood water or plasma water concentration, okay? When, in the instance of urea, BUN and EUN are equal, that tells you that the sieving coefficient is 1, okay? Sieving coefficient is 1. That means that can apply, that can freely pass through the membrane. So urea has a sieving coefficient of 1, okay? The inverse of a sieving coefficient is called a reflection coefficient. Reflection coefficient is mathematically essentially 1 minus the sieving coefficient. So urea has a sieving coefficient of 1 and a reflection coefficient of 0. Okay, those both mean the same thing. Okay, if you have larger molecules, an example of this would be myoglobin. It has a sieving coefficient of around 0.2. Okay, it can it can pass through the semi-permeable membranes that we use inefficiently, meaning the myoglobin concentration on the effluent side, if you're just using convective clearance, is 20% the concentration of myoglobin on the blood side. Okay, so this is in contrast to albumin, which has a sieving coefficient of 0, primarily because of the negative charge and its size, but the negative charge of albumin prevents its easy passage through the semi-permeable membranes, which we use, which are usually negatively charged. We're all negatively charged, okay? So any questions about solute flux in hemofiltration? Sieving coefficient and reflection coefficient are your parameters that explain these abilities for solutes to move. All right, let's then talk about the individual CRT modalities. We skipped over scuff. You can say scuff is the most simplest form of CRT solute clearance. So in this scenario, I am pushing plasma water across a semipermeable membrane. The sieving coefficient of urea is 1, so EUN and BUN are equal. That's dumped down the drain, so of course I am clearing urea, but the urea concentration does not change because I'm removing urea, yes, but I'm removing water at a proportional rate. And so the blood concentration of urea does not decrease before returning to the patient. Therefore, the patient shrinks, they lose extracellular fluid volume, but their small solute concentrations of urea, potassium, sodium, creatinine, none of these change. You can therefore see what is happening to the patient's intrinsic kidney function while on scuff. Scuff will not scramble your labs. You can still see what is happening with the patient's native kidney function while on scuff. This would be used for removal of extracellular volume excess, okay? Stated differently, small solutes and solvent are removed from the patient isotonically. EUN and BUN are 1. There is no change in small solute concentration, and the patient's ECF volume is contracted. Moving on to hemodialysis. In this scenario, it approximates what we're doing in intermittent dialysis with one major difference. In intermittent dialysis, remember the main determinant of urea flux is the blood flow rate. That's the biggest modifying factor for urea clearance. Remember, I told you the KOA, that's the maximal urea clearance by a dialyzer, is typically factors higher than what we demand, right? We're typically getting urea clearances of 300 mils per minute or less on intermittent dialysis. And your KOAs, that is your maximal urea flux for a dialyzer, typical dialyzer, is around 1,000 milliliters per minute. Okay, so several fold more than you demand from it. So dialyzer membrane's not limiting. Blood flow is the main limitation. In general, I'm running blood flow rates of around 400, dialysate flow rates of around 800, and then again, my urea clearance is somewhere around 270 or so. Not quite 300 is a typical urea clearance. All right. Now, in CRRT, the main determinant of clearance is going to be my dialysate flow rates. Okay. In this scenario, my blood flow rate is moving quite fast in comparison to my dialysate flow rates. So you can say that in essence, I have infinite blood flow, and as soon as urea moves into the dialysate, as soon as the concentration modestly drops by urea moving into the dialysate, it's quickly replenished by new blood with a urea concentration of 100. So in essence, the BUN in this side of the membrane functionally never drops because blood flow is so fast in comparison to dialysate flow rates. Therefore, the main rate limiting factor for urea clearance is how fast dialysate is moving across this membrane. Because again, the blood urea nitrogen in essence does not drop when you have sufficiently fast blood flow rates. What is that sufficiently fast blood flow rate? As long as blood flow rates are 2.5 times my dialysate flow rate, then you know that my EUN is approaching BUN, okay? Meaning my BUN on this side doesn't drop. It's functionally 100 milligrams per deciliter, and my effluent emerges near fully saturated as long as my blood flow rate is 2.5 times my dialysate flow rate. If I start running slower blood flow rates, what's happening is my BUN is starting to drop on this side, and my EUN is still becoming saturated, but it's getting saturated with a BUN that is lower than my blood urea nitrogen because the BUN on this side of the compartment is starting to drop. Okay? Now notice that this ratio of 2.5 should be familiar to you when we talked about urea flux or urea clearance for intermittent hemodialysis. So, what did we say with intermittent hemodialysis? We said that as long as my dialysate flow rate is 2.5 times my blood flow rate, then my urea clearance approximates my blood flow rate. So it's the flip. So a classic example is a dialysate flow rate of 500 and a blood flow rate of 200. That's the typical initiation regimen, right? When you run a dialysate flow rate of 500 with a blood flow rate of 200, you will get a urea clearance, in vitro urea clearance, right? That is about 200, right? We went over this. When dialysate flow rates are 500, blood flow rate is 200, you can see that my urea clearance is essentially approximating my blood flow rate. Now, the flip is true with CRRT. We're trying to get a blood flow rate that's faster, 2.5 times my dialysate flow rate. And when you do that, your urea clearance approximates my dialysate flow rate, okay? My EUN and BUN are roughly equivalent, and then my urea clearance is simply my 20 mils per minute of dialysate flow rate. 20 mils per minute would be a dialysate flow rate of 1,200 milliliters per hour. That's the numbers that you're more familiar with. Divide that by 60, you'll get a urea clearance, CRRT urea clearance of around 20 mils per minute. That would be about, again, 1,200 milliliters per hour of dialysate flow rate. Okay? Questions about that? This rule of thumb of 2.5 times my dialysate flow rate or an intermittent dialysis, the flip should now be owned by this audience, okay? No questions here? All right, then let's move on. Continuous hemofiltration. Again, solute clearance is by convection. You can either give fluid post-filter as we're doing it here or pre-filter. When you're doing post-filter hemofiltration, always my EUN is equal to BUN, right? I'm never losing efficiency. My EUN is always equal to BUN, okay? And so my urea clearance is going to be calculated in familiar ways. Remember, you familiar with the formula for clearance as UV over P. Remember, V is my urine flow rate, right? U is my urine creatinine, P is my plasma creatinine. When I'm calculating urea clearance for CRRT, I still have a flow rate. That's my effluent flow rate. Now my urine concentration, I'm saying, is my EUN, okay? My plasma concentration is my BUN. And I've told you, if you've used these rules of thumb that I'm giving you for dialysis, where my blood flow rate is at least 2.5 times my dialysate flow rate, then EUN to BUN are roughly equal, so they cancel out to 1. And so my urea clearance is now simply how fast is my dialysate running. I gave you the example of 20 mils per minute or 1,200 milliliters per hour of urea clearance. Okay, you can see that always, when I'm in post-filter replacement, EUN and BUN are always equal. And so, again, In this calculation of urea clearance, this goes to 1. My urea clearance is simply how fast is my replacement fluid flowing down the drain as effluent, okay? So again, that is how I would calculate a urea clearance. EUN always equals BUN, okay? Now, there's a disadvantage to doing post-filter hemofiltration. As you get further along the length of this filter, you're getting an increase in hematocrit, you're getting an increase in concentration of clotting factors, and so you're more likely to clot the filter as you push higher and higher replacement fluid flow rates. You try to reduce that hemoconcentration by minimizing the filtration fraction. Filtration fraction refers to what proportion of the flow on this side is pushed across the membrane. Okay, so if I'm running a blood flow rate of, let's say, 100, okay, 100 blood flow rate, and a replacement fluid flow rate of around 1,200 mils per hour, which is 20 mils per minute. I have a blood flow rate of 100. I have a ultrafiltration rate and a replacement fluid flow rate of 20 mils per minute. My filtration fraction is going to be 20 divided by 100, which is equal to, of course, 20% filtration fraction. Once you start pushing above this 20% filtration fraction, we become more and more concerned about risks for clotting. So you try and keep that filtration fraction relatively low by we could either decrease the replacement fluid flow rate, but if the patient needs that clearance, obviously you don't want to do that. So you have to increase the blood flow rate in order to reduce the filtration fraction and predisposition to clotting. Now, if the patient's not clotting, it's irrelevant. There's no need to achieve an arbitrarily low filtration fraction as an end in and of itself. If the patient's on heparin, is not clotting, run a filtration fraction of whatever you want. And then there's no harm to the patient by doing that. Okay? Pre-filter replacement fluid refers to the infusion of replacement fluid before you hit the hemofilter membrane. This is where you lose some efficiency. This is how you get a BUN concentration that is dropping, right? When I dilute the fluid, my BUN has to drop. The EUN can therefore not be my BUN1. It drops to this diluted value. It can never exceed this diluted value. That's what's being delivered to the blood side. So EUN is equal to BUN2 in pre-filter hemofiltration, okay? And that results in a reduction of efficiency of CRRT, and that also explains why the BUN drops in the patient. You're diluting the blood, not post-filter, but pre-filter. The advantage of this is that you don't get the hemoconcentration that occurs with post-filter hemofiltration. Presumably that reduces filter clotting, okay? I will tell you my experience is adding more pre-filter fluid has minimal effect on clotting risk. I don't typically use that as a major means to reduce clotting in my patients. Usually I find it's no better. One reason that is that as you increase replacement fluid flow rates, whether it's pre-filter or post-filter, that has to correlate with an increase in transmembrane pressure, right? The only way to increase replacement fluid flow rates is to increase the rapidity of fluid flux across the membrane. If you don't do that, then your patient will get volume overloaded. What you put in If you increase it, you have to take off. The way you take off more fluid is with the application of a higher TMP. One of the decision factors for your nurse in clotting, she or he is monitoring the TMP. And so adding more replacement fluid in the pre-filter mode can sometimes raise your TMP, resulting in a nurse that's concerned for clotting even more. Again, their disadvantage is the reduction in efficiency of clearance. Why? EUN to BUN ratio is no longer 1, right? That dilution step makes EUN to BUN something less than 1, right? And so my clearance is going to be a proportion of my replacement fluid flow rate. No longer is it going to be identical to my replacement fluid flow rate. That's the mathematical representation of this loss of efficiency. EUN to BUN ratio drops below 1 in pre-filter mode. Now, as long as your blood flow rate is at least 6 times your replacement fluid flow rate, you can mathematically calculate this. BUN or EUN to BUN ratio is at least 85%. Okay? That means, again, this EUN to BUN ratio, it's not going to be 1, but at least it will be greater than 0.85. So you know that my clearance should be within 85% of my replacement fluid flow rate. Okay? This is easy math because remember, your blood flow rate is in mils per minute. Your dialysate flow rates are going to be in mils per hour. So if I want to make, did I say dialysate flow rate? I meant replacement fluid flow rates, mils per hour, right? If I want to make sure that QD or QR, I keep saying D, replacement fluid flow rates are greater than, excuse me, QB is greater than 6 times QR, it's actually easy math, okay? The net mathematical operation is simply drop a 0 from your blood flow rate, okay? So if you have a blood flow rate of 150, right? As long as your replacement fluid flow rate is 1500 or less, you have achieved this criteria. Okay? So easy math. Drop the 0 in order to compare the replacement fluid flow rates and blood flow rates. That would assure that at least your blood flow rate is 6 times your replacement fluid flow rate. Okay? Finally, hemodiafiltration is obviously the combination of dialysis plus replacement fluid flow rates. I get both diffusion and convective clearance, and you can do pre or post filter replacement fluid flow rates. There's a hybrid modality that is called prolonged intermittent renal replacement therapy. This is the individual who is getting sort of CRRT-like prescriptions for less than 24 hours a day. For instance, something like 8 hours at night during night shift. A typical prescription for prolonged intermittent renal replacement therapy would be a blood flow rate of around 200 to 400 mils per minute, dialysate flow rates of 6 to 12 liters per hour, and these times of around 8 hours. Now, I'll once again challenge you to use the standard weekly KT over V. Remember that? We talked about that in our discussion around intermittent dialysis as a way to compare clearance with continuous CRT, right? We've already explained how you can calculate a clearance with CRRT. So this is simply your K in KT over V, right? Clearance is calculable, right? You know how to calculate that. You know how to calculate V, of course. V is simply total body water. The K and the T is, for a 24-hour treatment like CRT is going to be, uh, you know, uh, 24 hours or 1,440 minutes, depending on the units you choose to use. So figure out what your single pool KT over V for CRT is. Map it along this line. You'll find that you're going to be somewhere around here on this line, which will be equal to a standard weekly KT over V that's really, really high compared to those that you're achieving with PD or thrice weekly HD. Okay. Now, if you start wanting to prescribe these nightly therapies with PERT, which would be following this 7 time per week curve, you should be able to calculate. If I want to get, something like a CRRT standard weekly KT over V, maybe I don't need to be way up in this part of the graph. I'm going to arbitrarily say a standard weekly KT over V around 6 might be just fine. That's my goal. You should be able to find out what prolonged intermittent renal replacement therapy prescription will get you a single pool KT over V that's on this line somewhere around 0. We can say 0. If I wanted to get a 5, I would say 1.2 for that treatment. That will give me a standard weekly KT over V of around 5. Okay. You should be able to prescribe that with the principles that we've described. Okay. Remember, your clearance will be a function of dialysate and blood flow rates. As long as you're achieving dialysate flow rates that are less than 2.5 times my blood flow rate, you should be able to intuit what your clearance, your K, is going to be in order to plug it into these formulas and devise a prolonged intermittent renal replacement therapy regimen. Okay? Questions about that? That's all I'm going to do. I'm going to let you, again, struggle with that so that, and then if we're on service and we have an opportunity together to prescribe PERT, I'll ask this. I'll always ask this of the fellow if we ever have a chance to prescribe this.